And thank you for joining us today. I'm delighted to welcome you to our programme, Advances in the Management of Renal Cell Carcinoma, Addressing Gaps and Elevating Care for Patients. As I'm sure you know, there's been a huge increase in our understanding of the biology of the disease. This includes particularly around immune responsiveness. We've seen an expansion of systemic therapy options, particularly with adjuvant strategies for high-risk operable disease. But we've also seen a lot of changes in the first line and later line therapies. These changes have brought a massive opportunity to our patients, but they've created a series of uncertainty. And I hope that these today will address some of those uncertainties. One of the questions, I guess, is how do these evolving data sets influence our sequencing decisions? And how much of what we talk about is evidence-based and how much is weaker, less robust data? Today, I'm planning to cut through this complexity if possible, and we'll review some of the latest data, of course, and also some of the data that makes up the current guidelines. There'll be some real-world decision-making and some cases towards the end. Specifically, I'd like to thank Creative Educational Concepts for supporting today's activity. Creative Educational Concepts are jointly accredited by the ACCME, ACPE, and ANCC, enabling high-quality continued education for the entire healthcare team. This activity may include discussions of products or devices that are not currently labelled by the US FDA. The faculty have been informed of their responsibility to disclose to the audience if they'll be discussing off-label or investigational uses of any non-approved products or devices. This is me, Tom Poles, and my conflicts of interest. Here are 3 learning objectives. So, evaluate the latest data and consensus guideline recommendations on systemic treatment approaches for patients with operable and advanced renal cancer. Number 2, develop personalized treatment plans for patients with RCC that integrate patient-specific factors, risk assessment, and guideline recommendations in community oncology settings. And number 3, integrate strategies to revive management of AEs across multidisciplinary care for patients with RCC. So here we are, the advances in the management of renal cancer. This slide talks about prognostic factors and recurrence after surgical management of RCC. Nephrectomy, partial nephrectomy, or total nephrectomy, usually robotic these days, remains the standard treatment for localized disease. But there are still risk of relapse, and this risk of relapse can vary. There are key risk factors associated with relapse. Tumor stage and grade are the 2 that worry me most. Necrosis and sarcomatoid differentiation, they are associated with increased risk of relapse, but sarcomatoid differentiation particularly is also associated with increased response to immune checkpoint inhibition. Lymphovascular invasion is in some prognostic indices, but not all of them. And this will really result in a risk of recurrence from somewhere in about 20%, that's 1 in 5, all the way up. You can get some patients as high as an 80% risk of recurrence, dependent on all of those factors, including T-stage, grade, and necrosis. Patients tend to recur, in my experience, within the first 2 years, but we all know in renal cancer, there are also some late relapses. This persistent risk of recurrence underscores the need to evaluate new and effective treatments in this setting. You'll be aware that we spent a long time trying to develop VEGF-targeted therapies without success in this environment. And so we've moved on and looked at adjuvant immune therapies, particularly adjuvant immune checkpoint inhibitors in this setting. It hasn't been entirely successful. Indeed, there have been negative trials. Emotion 010 was adjuvant atezolizumab versus placebo. This failed to meet its primary endpoint of disease-free survival. It was a robust study. It was a well-conducted study. It's a PD-L1 inhibitor, and we know PD-L1 inhibitors perhaps may be less active than PD-1 inhibitors, but that takes us to the Checkmate 914 study, and that explored single-agent nivolumab in Part B, and in Part A, nivolumab plus ipilimumab, both of these versus placebo. Neither of these trials hit their primary endpoint with statistical significance. Subset analysis showed some subgroups potentially benefiting, but overall it was a negative trial for DFS and for overall survival. There was a shorter duration of therapy, only 6 months in these trials. A year of therapy was given in the atezolizumab and pembrolizumab studies in this setting. And the ipi-nivo perhaps was more difficult to tolerate. However, we've not come to a good conclusion as to why these trials are negative. Prosper's, the final study, it looked at things in a slightly different way. It gave one perioperative cycle of nivolumab and then adjuvant nivolumab versus surgery alone in this setting. This was an investigator-initiated trial. To me, it looked like a lower risk group of patients compared to perhaps some of the other trials. Nevertheless, this trial was also negative. So these three trials together have created some uncertainty. Keynote 564 looked at a year of adjuvant pembrolizumab versus placebo. It was a large randomized phase 3 study. Overall, it was well conducted again. There was a relatively low amount of censoring in both arms. The study hit its primary endpoint of disease-free survival and overall survival. We have now 5-year data, and we have attractive hazard ratios for EFS, but also for OS at 0.66. These are statistically significant. The absolute difference in risk is about 7% at particular landmarks for overall survival for pembrolizumab versus placebo. Of course, these drugs are associated with life-changing toxicity in some patients, classically those endocrine adverse events, perhaps some rheumatological problems, and others as well. The incidence of serious adverse events, 20.7% in the study arm and 12% in the control arm. The group of patients that took part in these studies were higher risk. It was T3 and T4, particularly. Also M1 NED. And finally, patients with high-grade disease could be included in the T2 setting. Keynote 564 adjuvant pembrolizumab changed standard of practice and has strong recommendations in a number of guidelines. So what factors might explain the positive results seen in pembrolizumab compared with the other negative trials, such as Emotion 010 and 914? I've spent quite a lot of time thinking about this. I think the answer to this question is the following. I think there's no underlying single reason why one trial was positive and the other were negative. As I said previously, I think the Prosper perioperative trial had lower risk patients. I think Emotion 010 had PD-L1 therapy, and Checkmate 914 perhaps shorter periods of therapy. In the end, no one actually knows the answer to that question, but Keynote 564, a robustly conducted study with pembrolizumab, which after all is the most widely used immune checkpoint inhibitor, is a positive trial which is practice changing, and indeed, I recommend it for my patients. Moving on, can we find other biomarkers associated with outcome in this perioperative setting? There's been a lot of excitement in other tumours, such as bladder cancer, about circulating tumour DNA. And indeed, some tumours employ longitudinal ctDNA monitoring to assess response and resistance to treatment. A little bit of work has been done in this setting in advanced cancer, particularly advanced renal cancer, advanced clear cell renal cancer. And we can show that many patients with advanced clear cell renal cancer are ctDNA positive. However, localized disease, post-surgery, only a very small percent of patients are ctDNA positive. Clear cell renal cancer, with the current technology we have, is not seen as a classic ctDNA shedder. So yes, of course, CT and dynamics may provide some tools in the future, but I think we're not currently there yet in clear cell renal cancer. So do current data support routine use of ctDNA testing after nephrectomy in localized RCC? The answer to that's no. Does ctDNA status influence your decision to recommend adjuvant pembrolizumab? Again, at this point, that would be premature. We're going to switch gear now, if we can, to first-line systemic therapy options for advanced clear cell renal cancer. First-line clear cell renal cancer is an area that has been widely explored. Again, as is the case in the adjuvant setting, this doesn't apply to non-clear cell, particularly papillary renal cancer, where the studies are different. First-line therapies become increasingly complicated because of all the different options, but actually it's fairly straightforward. And I'm going to try and explain to you why that's the case in a minute. It's straightforward because we have two classes of drugs, the immune checkpoint inhibitors and the VEGF-targeted therapies. We know that doublet therapy, either dual immune checkpoint inhibition or PD-1 therapy with VEGF-targeted therapy, are all associated with benefit compared to sunitinib. The overall survival benefit for the two approaches look actually very similar. Ipi-Nivo, PD-1 plus CTLA-4 is a standard treatment. It's probably less good at getting initial control of disease compared to the VEGF-TKI PD-1 combinations, but the long-term survival outcomes look good. And of course, you don't need to give chronic VEGF-targeted therapies. The VEGF-TKI PD-1 combinations, there are three of them. Axi-Pembro was first, Cabo-Nivo was second, and lenvatinib pembrolizumab was third in terms of how they were produced. If you look at the response rate, the PFS, and the OS, and the adverse event profile, there are more similarities than differences between them, and cross-trial comparison can be fairly futile. Particularly in intermediate and porous disease, these combinations have outperformed sunitinib alone. There is an ongoing debate because the OS signal in the good risk patients is less clear, although response rates for the VEGF-TKI PD-1s and PFS for the VEGF-TKI PD-1s are both longer. Ipi-Nivo is not recommended widely in good risk disease because the initial results from the 214 study suggested it was inferior to sunitinib. As time has gone by, that statement seems less compelling, and indeed in the most recent guidelines, there is actually balance where people say Ipi-Nivo is not an unreasonable option. The IMDC risk stratification tool is actually a good prognostic indicator. And as I've described it, it separates patients into good, intermediate, and porous disease. We've overcomplicated the IMDC risk groups. The IMDC risk groups are prognostic. It's a blood test, and it gives you an indicator about how active the cancer is from the blood. And the way that works is if you've got a big disease burden, it's growing fast, you become anemic. And because it's releasing lots of growth factors, your platelet count goes up and your white count goes up. Those are not markers of response or to immune therapy. So yes, they're markers that the cancer's worse, and yes, it's strongly prognostic. But no, it's not a marker, of PD-L1 sensitivity. Obviously, it's not. Obviously. So the reality is we've adopted this biomarker from a blood test, not from a prospective tissue biology sample. And in the original data cuts of the clinical trials, there were indicators, in the runestones pointing towards a link between the two. But actually now with the maturity of these data, it looks like it's actually just prognostic and not predictive of Ipi-Nivo. So when you say we shouldn't give Ipi-Nivo to good risk and we should give VEGF-TKI PD-1 to poor risk, I think that's probably upside down. And so I'm just encouraging people to look at the patient in front of them. And, if they've got, a patient who's relapsed with good risk disease, relatively soon. I mean, a year and 3 months after an operation with lung only metastasis, they've got a really good chance of doing really well with ipi-nivo in reality. So that doesn't mean they have to have ipi-nivo. You can give them axi-pembro or lempen if you want to. Of course you can. But the issue is that these hard and fast rules saying ipi-nivo doesn't work here, well, that's not right. And VEGF-TKI IO is by far the best in porous disease. That's not right. So I just want people to be mindful of that because I want to make things simple. And again, don't worry too much about which drugs you give, just give them well. Don't worry too much about prognostication in terms of or predictive IMDC risk. This is ipi-nivo. Again, it doesn't matter. It's much more important you've got that support network. You spend too long picking up therapies or picking therapies, or so that's where I am with this. And ipi-nivo is not currently licensed by the FDA or the EMA in good risk populations. Evolving real-world considerations such as prior adjuvant pembrolizumab, rapid progression of disease, comorbidities, baseline lab abnormalities will also be important in influencing decision-making. To give you a quick summary of that, what I would say is if you've had prior immune checkpoint inhibition, we've done randomized trials in the metastatic setting showing quite conclusively that sequencing immune therapy doesn't work. What we've not done is we've not done studies after adjuvant settings to see if re-challenge with immune therapy works. Nevertheless, many people, such as myself, are somewhat skeptical that if it's negative in the metastatic setting, it would then be positive post-adjuvant pembrolizumab. But I would admit that if a patient relapsed a long time after adjuvant pembrolizumab, re-challenge with classic first-line therapy, ipi-nivo, or VEGF-PD-1 combinations would, in my opinion, be reasonable. I think disease tempo is also an important consideration. Rapidly progressive disease in key sites such as liver and bone metastasis. I'm much more comfortable with VEGF-TKI PD-1 combination because the response rates are higher and the PFS is longer. I'm anxious about giving those patients ipi-nivo. Comorbidities, perhaps patients with active autoimmune diseases or recent history of autoimmune diseases, you might be more comfortable with a VEGF PD-1 than a dual immune combination. Baseline abnormalities concern me that much, but a patient with a transaminitis would clearly worry me. Also, we test virology for patients for hepatitis B, of course, to make sure there's no reactivation of latent viruses. The balance of efficacy and tolerability is a key consideration. Long-term treatment goals are becoming critical for our patients. 50% of patients are living for 5 years, and most of those patients will spend most of that time on therapy. Frontline choice is the most important choice to make in advanced disease because these patients will spend most time on this therapy, and getting education and training about the best way of giving these drugs is really important. I'm going to start with ipilimumab and nivolumab, if I may. This trial feels old now. You can see the PFS curve and the OS curve, particularly at the beginning. The curves are very close together for PFS. They only go apart after a landmark, but there is that fabulous PFS plateau. Now, there's quite a lot of censoring on that curve. Nevertheless, I think it is true that about 30% of patients have rapid progression of disease, but a similar proportion have a sustained progression-free survival. And these patients, many of them are just on single agent Nivo, or indeed many will stop Nivo at 2 years. This is attractive, but as I said before, it's not the best regime for initial control. The overall survival curves are sustained and are significant. You can see the curves go apart and they stay apart, and we've got the longest follow-up for this cohort. Indeed, the longest follow-up now is coming towards 10 years. The AE rates are similar between ipi-nivo and sunitinib, but actually very different. Sunitinib is more chronic toxicity, fatigue, sore mouth, diarrhea, hand and foot syndrome, whereas Ipi-Nivo is more dramatic during the first 12 weeks with activating immune type syndromes, particularly those syndromes that we talked about before, transaminitis, pneumonitis. There are other rare adverse events, myocarditis, etc., endocrine abnormalities, reactivation of immune diseases. But once you're through that first period of therapy, I think chronic therapy with single agent nivolumab is more straightforward than sunitinib. If we then move on to the next slide, we can see the next regime is 9ER. Checkmate 9ER is nivolumab plus cabozantinib. Again, you see the PFS curve and the OS curve. Both go apart. Both stay apart. After 5 years, there's quite a lot of censoring, and the curves, the OS curves, appear they may come back together. Actually, when you look at the landmark OS, when you compare the landmark 5-year OS for Cabo-Nivo and for Ipi-Nivo, they look very similar. Cross-trial comparisons after 3 or 4 years, when censoring and subsequent therapies become relevant, actually is not that helpful. It's another study which has impressive PFS and OS. You can see here, unlike Ipi-Nivo, there's a much bigger difference in response and much bigger difference in PFS. And importantly, unlike Ipi-Nivo, where the benefit appeared mainly in the intermediate and poor risk groups, the benefit here and the license is across all IMDC subgroups. The adverse event profile associated with these drugs. There are more adverse events, as you would expect, with the combination than sunitinib alone. And indeed, these patients who have cabozantinib continue on that until progression. And so there is some of that chronic VEGF TKI toxicity that I described before. Keynote 426, Pembro-Axi, has a similar story actually to Cabo-Nivo. Again, the OS curve goes apart, it stays apart. Then after 5 years, after that censoring, that appears to come back together again. I wouldn't be talking about cross-trial comparisons if I were you. And again, you can see the landmarks of all of these trials at specific time points are very similar. The response rate and the PFS, quite similar in many ways to Cabo-Nivo, and active across good, intermediate, and poor risk subgroups. I've not talked much about the PD-L1 biomarker. At the moment, there isn't evidence that the PD-L1 biomarker is particularly effective in this disease. And then finally, the fourth regime that's licensed, pembrolizumab. This is considered perhaps to have the highest response rate at 70% and the longest PFS at 23 months. Again, the Kaplan-Meier curve looks quite similar to the other VEGF TKI PD-1 Kaplan-Meier curves. The landmark analysis for OS looked very similar to the other 3 regimes. Again, great initial control of disease. Again, the downside, long-term toxicity with the VEGF TKI. Some people say lenvatinib might be the most challenging drug to give. We've not done direct comparisons across different VEGF TKI therapies, so I'm not sure we can say that. And with dose adjustments, I think it's very or relatively easy to get good control of disease and good toxicity profiles for our patients. The response rates of 71%, probably the highest that we've seen. But again, I wouldn't want to be making cross-trial comparisons. The logical step is, why not try and give all 3 drugs together? We did that in Cosmic 313 with cabozantinib, nivolumab, and ipilimumab. It was actually a positive trial, but Ipi-Nivo was the control arm. And when you look at response and PFS, and you do indirect comparisons of Cabo Ipi-Nivo, it doesn't look a lot better than Cabo-Nivo. Yes, it might be better than Ipi-Nivo, but remember, Ipi-Nivo had the shortest PFS and the lowest response rates. And then here you can see the OS, the overall survival shows no difference between the two, with a hazard ratio of 1. And therefore, with, dare I say, a modest PFS and response compared to Cabo-Nivo, higher than Ipi-Nivo, but compared to Cabo-Nivo, modest, with no overall survival advantage. we don't widely recommend this triplet. There are new drugs being developed, and belzutifan is an agent which is gaining attention. It's a HIF2 alpha inhibitor. It has a direct anti-tumor effect. It has a different mechanism of action to the VEGF TKIs. And when you combine it with cabozantinib, the VEGF TKI, you can see response rates of 70%. Now, these are relatively small cohorts, and they're single-arm cohorts. But we have randomized second line, randomized front line, and adjuvant trials ongoing. We know from press releases some of those trials are positive. So here we have a 59-year-old patient with high-risk localized renal cancer. They've had a year of adjuvant pembro. 18 months after finishing therapy, they show new multiple pulmonary lesions. They're in great shape with a PS of 0, no major comorbidities. What's our first-line treatment? Are we happy retreating when it does feel like quite a late relapse? I personally probably would be happy retreating with an immune checkpoint inhibitor, number one. And number two is it a VEGF TKI combination? For me, it would be a combination of VEGF TKI PD-1. Perhaps if they had progressed on adjuvant pembrolizumab under those circumstances, I would just be adding in a drug like cabozantinib and stopping the pembrolizumab. Case number two, a 63-year-old patient with de novo metastatic renal cancer and poor risk features. These include anemia and elevated neutrophil count and less than a year since diagnosis. Badly symptomatic disease, lung and bone disease. Which treatment's the most appropriate? Well, lenvatinib and pembrolizumab for me here, best response rate, longest PFS. They're in good shape. I'd want to be giving them lenvatinib and pembrolizumab. But you know what? If you said to me you're giving them cabo-nivo or axi-pembro, I'm more than happy. My message to everyone has always been pick one and use it well. The major difference between these regimes will be determined by the skill of the doctors giving treatment, not necessarily the words written on which drug on the box that they're taking, because adverse event management, treatment reductions, treatment holidays, supportive medications are probably more important than the choice of therapy. And then the next case, a 58-year-old individual, again, de novo IMDC, favorable risk, clear cell renal cancer, and greater than a year from diagnosis, low volume disease, a few pulmonary metastasis. What's our first line treatment? I've got to tell you, this is the most difficult of the three for me. I think they're young and well. I think early immune checkpoint inhibition does really help some patients. So I would be keen to give them VEGF TKI PD-1 therapy. I know there are people out there who'd be itching to give them ipi-nivo, but sadly it's not licensed in good risk disease in either the United States or in Europe. And then there'll be the skeptics who'll say, well, single agent TKI such as sunitinib's never been beaten. Why not give that and see where we go? So clinical investigation perspectives approach to first-line therapy. How do we approach first-line therapy for advanced RCC, and how does IMDC risk status affect our decision-making? As I said before, I think the clinical investigations, CT, chest, abdomen, and pelvis is crucial. I do a brain scan at baseline as well, number one. Number two, I need that tissue biopsy. I want to know exactly that it's a clear cell cancer. I'm not super excited about grade, but I'd like to know if there's sarcomatoid features. That's number two. And of course, I want a blood test to know their IMDC risk, and that will determine the treatment. As I described in those cases, patients with rapidly progressive advanced disease, VEGF TKI, PD-1, really important. I tend to give lenvatinib and pembrolizumab. If you want to give axi-pembro or cabo-nivo, you're more than welcome. Pick one and use it well. How does my approach to first-line therapy change if patients receive adjuvant immune therapy? If it's more than a year since their prior adjuvant immune therapy, I'm happy re-challenging. Less than that, I'm less happy. I'd like to see some data in this setting. The next part of this is to switch gears a little bit and go into contemporary approaches to second line and subsequent treatment in renal cancer. In this second and subsequent line area, we're not curing that many patients. It's a lot of it is around stabilization of disease. But I think it's also relevant that, ipi-nivo PFS, maybe 10 months, perhaps shorter than that even, and overall survival median, maybe 60 months. So although the ambition here may be less, actually for many patients, more time is spent after first-line therapy than on first-line therapy. So we're going to talk about treatment choices, but we're also going to talk about maximizing efficacy and minimizing toxicity. There are a number of studies I'm going to run through, if I may, and the first one we've picked is TiVo3, but I could have picked other studies. One of the issues around TiVo3 is we've done previous studies like the AXIS trial with axitinib versus sorafenib, for example, and the METEOR trial of cabozantinib versus everolimus, but they were in the pre-IO era. And so these are studies that are in or partly in the post-IO era. And TiVo3 is one of those trials where we compared tivozanib, which is an active VEGF TKI therapy, with sorafenib. We showed a PFS advantage, which was statistically significant, but no statistically significant overall survival advantage. And there are subsets of data, of course there are, where you can find maybe advantage here, maybe an advantage there. But in the end, I think the key to this is it underpins the point where sequencing VEGF TKI is important. And from a PFS perspective, tivozanib is better than sorafenib. But tivozanib's not perhaps the most famous drug in this space. Cabozantinib we've been using for a long period of time, mainly because of the METEOR trial where it beat everolimus for overall survival. The Cabo Point trial was a study which was a monotherapy study. It was also a single-arm trial. Only 119 patients, so not a huge study, but monotherapy was fair with a response rate of 40%. There are two cohorts to the trial, which complicated it a little bit. And cohort A and cohort B are outlined in the slide up here. But you can see the response is impressive for cabozantinib, not randomized, PFS at 10 months. And actually, I'll show you 40% and 10 months in coming up as well. And it's a consistent signal. Because here below Cabo Point, which was the single-arm trial, CONTACT-3. Now, CONTACT-3, cabozantinib plus or minus atezolizumab, spectacularly negative trial. But at the same time, you can see for the monotherapy cabozantinib, response rates of about 40% and PFS of 10 months. So very consistent with Cabo Point. And this kind of underpins cabozantinib as a really active agent in this area. But then tivozanib comes in with a similar study, TiVo plus or minus nivo. Nivolumab, again, doing nothing in this space. The tivozanib was complicated in the combination because it was given at a slightly lower dose, but at monotherapy at standard doses, you can see here PFS 7 months and OS 22 months. And response rates, again, were strong. So I think it's fair to say that there's quite robust data for tivozanib and cabozantinib. To be honest, my perspective on this is axitinib, cabozantinib, tivozanib are largely interchangeable in this space. Perhaps cabozantinib has the most robust data, but they've not been compared head to head. So under those circumstances, it really is a case, from my perspective, of picking one, using it well. Now, belzutifan, however, is a different drug. This is a HIF-2 alpha inhibitor. It has a direct effect on the cancer cells, and it's been compared with everolimus. in a randomized phase 3 study, LightSpark-05. You can see a nice tail on this curve. Again, about 25% response rates, very similar to tivozanib. Heavily pre-treated patients, no overall survival benefit. But there is a real tail on this curve. And I think the curve shape is interesting. And it's beginning to be apparent to me anyway, that I think there's a subgroup of patients that do really well with belzutifan that haven't necessarily responding to sequenced VEGF therapy. It doesn't mean it's better than axitinib or cabozantinib, and certainly hasn't been tested against a VEGF TKI, but is an attractive agent. And there's a study looking at belzutifan and lenvatinib. We know that trial is LightSpark 11, and this is potentially a practice-changing study. There's another lenvatinib combination, though, and that's lenvatinib with everolimus. And lenvatinib everolimus is widely approved both in the EMA and the United States in VEGF-resistant disease, but it hasn't been tested before really robustly in randomized phase 3s, only in phase 2s. And here's a randomized phase 2 against cabozantinib. And I like this study because the previous study was against everolimus, never hit overall survival. But everolimus isn't a fantastically active drug. But here against cabozantinib, you see higher response rates. And we also see better progression-free survival, no overall survival advantage. Again, randomized phase 2, not randomized phase 3. But this strengthens the data for lenvatinib and everolimus. And actually, it's changed my mind a little bit. I've been a bit negative about lenvatinib everolimus because I think you have to be everolimus for OS. But here, you don't necessarily have to beat cabo for OS. Beating it for PFS is pretty hard, not been done before. Randomized phase 2 with all the caveats for that. Let's take a case of a 55-year-old patient who progressed on nivolumab and ipilimumab after 5 months. It's got a pretty rapid response, but maintained a good performance status, eligible for all therapies. What do we consider as another ICI-containing regime outside of the clinical trial? And I've got to tell you, those 2 trials we showed before, tivozanib plus or minus nivolumab, hazard ratio for OS of 1.12. And then, of course, CONTACT-3 with atezolizumab. So there we go, cabozantinib plus or minus atezolizumab, hazard ratio 1.0. Re-challenge with immune therapy in this disease has not been proven to be beneficial. Done 2 randomized trials showing we shouldn't do it. I wouldn't be re-challenging with immune therapy under any circumstances in this particular patient after 5 months. So what I know about renal cancer, a bit about bladder cancer too, and actually a tiny bit about prostate cancer with immune therapy, is it does appear that patients seem to be pre-programmed to respond to immune checkpoint inhibition. All of the data that we've seen in terms of the balance between immune activators and inhibitors and how one changes or how influences that balance, it looks like the existing immunity that is currently there is really important in determining response to immune checkpoint inhibition. And that appears to be the case in kidney cancer. So therefore, if you can't really change that balance, specifically that pre-programmed balance to respond or not, therefore re-challenge with immune therapy that hasn't worked before is unlikely to have a different effect. So although immune therapy results in upregulation of things like T-cell infiltration, CD8 expression, and can change the balance between T-cell activation and memory T-cells, Tregs, you can change that balance. In the end, that interaction, that dynamic change is more of a sort of a pharmacodynamic effect and isn't changing the long-term immunity. And the reality is if the patients don't respond the first time, they don't seem to then respond a second or third. I think single-agent VEGF TKI therapy is the standard of care. The one area where we haven't resolved immune therapy re-challenge, in my opinion, is those patients who relapse a significant period after adjuvant immune checkpoint inhibition, adjuvant pembro. And that's an area which I think we need to look at in more detail. Let's move on, if we can, to clinical investigator perspectives. Just have a look at navigating some of these treatment options after progression on first-line therapy. Patient selection is important. So not all patients are the same. What regime did they have first off? And of course, how did they do with that regime? Did they progress through that regime? Or did they have an initial deep response and then relapse from there? And then, of course, the issue is, have they previously had adjuvant immune therapy? Both of these factors are really important. So how do I look at this? Number one, if you've had prior immune therapy, I would be reluctant to challenge with repeat immune therapy unless there's a significant relapse after the first period. That's number one. Number two, in that frontline space, when you're choosing therapy after first line therapy, does it matter if you've had ipi-nivo or a VEGF TKI IO for second line therapy? The answer to that question is actually a little bit. But in the end, we're sequencing VEGF TKI therapy. We're not sequencing with immune therapy. So what I say to people is pick a drug you've not had before. Now, my preference in this space to date has been cabozantinib, but looking at the recent data, I think lenvatinib and everolimus is a very reasonable alternative to that in view of that recent randomized phase 2 data. If you said to me you're going to give axitinib, I wouldn't say you're wrong, or indeed tivozanib. What about in the third line space? Well, in the third line space, belzutifan becomes attractive for some of the reasons I described before. I think it's also true from a toxicity perspective, belzutifan may be better tolerated than chronic VEGF TKI therapy. And then, are there any special considerations about this immune therapy rechallenge? I don't know. I do think those patients that maybe relapse many years after prior immune therapy, after having a complete response, ipi-nivo, deep, durable response, stop therapy after 2 years, relapse 5 years later. Yeah, of course. Why would you not be thinking in that? But that's 0.1 or 1% of patients. For the vast majority of patients, you get one good go at immune therapy. What about proactive AE management? I think this is extremely important. I've been saying for a long period of time, the way we manage our patients, the way we interact with them, and the support structures they have around them are more important than the choice of drugs. Axitinib, given well, is much better for patients than cabozantinib, given poorly, with no good support structure, no dose reduction advice, no dose interruption advice, no supportive management, no hospital forum for them to come to, no hotline number, and no nursing support. So the choice of drug is less important than the supportive structure around. And of course, the AE prevention management, I say to people, see a lot of your patients during the first 12 weeks, particularly the first 6 weeks. That's when patients get into the trouble. If you get in the first 6 weeks right, you get the right dose, the right regime, patients will do well or do better from there. I wanted to do a little bit on immune-related AEs, of course, because these are somewhat unpredictable. Many of these on this slide here, neurological, respiratory, renal, hematological, dermatological, endocrine, gastrointestinal, cardiovascular, and ocular, many of these happen in less than 1% of patients. But when you add them together, they come to quite a significant number. 1% cardiotox, 1% neurotox, 1% ocular tox, 1% endocrine, massive endocrine dysfunction, not hypothyroidism. And when you pull that together, it probably comes to 10 or 15%. So what I say to people is these adverse events tend to occur during the first 3 or 4 cycles of therapy. And I would begin to say to you, and I know that all of you are very familiar with this, but one does need to get familiar with these weird and wonderful adverse events. And if you're not sure what it is, always think perhaps it is immune-related toxicity. And here's some red flags, and here's a slide giving you some outlines of those. Which ones worry me? Well, early significant transaminitis, if not controlled, can actually be a marker of other problems occurring as well. So I've seen a rapid transaminitis and then patients going into hematological tox, pulmonary tox, etc. So I look out for that and I would treat that aggressively. Let's get it back to normal, liver function back to normal, 3 weeks off steroids. Well, the mistake people make is I've got to get the drugs back in, and then it becomes a roller coaster, and then it starts and it stops and it starts and it stops. You just need the roller coaster train needs to stop. Needs to come down, stop completely. Otherwise, you're back up and back down and back up and back down, and that's never really works out for me. Interstitial lung disease obviously worry us, particularly the pituitary disease of endocrine dysfunction, and then this rare and wonderful demyelination and cardiac toxicity. When I say wonderful, I mean unpredictable rather than good. Clearly, it can be disastrous for patients. Graded management of immune-related toxicities go from grade 1 to 4. I've got to tell you, they haven't been super helpful for me. I think each of those which I described before, the grades aren't really that helpful. Grade 3 transaminitis, well, you could re-challenge some of those patients actually if you get that down to normal, but you certainly grade 3 cardiac or neurotox, you wouldn't want to be re-challenging in my experience. So again, clinical experience more important than the one-size-fits-all approach. I think you just need to be alert to the fact that that anything can happen at any time. And while it becomes less frequent as time goes, I've seen it happen 6 months after completion of immune therapy. So I just think you just need to be very cognizant that this is an ongoing issue for your patients. And never forget the immune-related toxicity can do almost anything. And then VEGF toxicity. Well, where are we with VEGF toxicity? Again, I say to patients when I see them, the first 4 to 6 weeks, particularly, is all about getting used to the drug, getting the right drug for you, managing your toxicity well. And my take on this, for what it's worth, is early dose reductions, encouraging treatment holidays during this period of time. Close management of hypertension is really important. And then family support, patient information, nursing support, and hospital support is much more important, as I've said before, than the choice of drugs. What's the principle of this toxicity? Well, again, grading isn't always that helpful, but early intervention, early treatment breaks are really important. Really liberal on dose reductions. Remember, go back to the Meteor trial, cabozantinib versus everolimus. The majority of patients reduced from 60 to 40. That didn't mean we got the dose wrong, because many patients kept going on 60. But what it meant is there was a real art to giving this treatment. One of the real challenges is particularly if you started a patient on a VEGF TKI and an immune checkpoint inhibitor, a PD-1 therapy, it can be very difficult to determine which of those two drugs is generating the adverse event. And actually, it's not black and white. It's not two circles unrelated to each other. It's actually a Venn diagram with a degree of toxicity in the middle. So both of those drugs, for example, will make a transaminitis worse. So both will cause a transaminitis by themselves. You give them together, that will increase. Same applies for skin toxicity, other toxicity as well. So the first thing to do is if you have an immune-related adverse event, or you have a VEGF TKI adverse event, unless you're 100% clear what you're doing. So hypertension, for example, would almost always be VEGF TKI. Mucositis, almost always VEGF TKI. For example, pan-hypopit, destroy the pituitary, that's almost exclusively immune therapy. But fatigue and rash and transaminitis, a lot of them are both. I always say to people the following. Number one is if it's serious and you're worried and it's escalating quickly and it could be immune related, always start steroids. Because you might not have time to let the VEGF TKI wash its way out. But for example, if it was diarrhea 2 or 3 times a day, We know diarrhea is serious. We know diarrhea can be caused by both. It might say, and it's axitinib, it has a 6-hour half-life. It might say, give it 48 hours, see where you are, speak to the patient every day, because if you've got grade 1 or grade 2 diarrhea with immune therapy, you wouldn't want to sit on that for a week or two. Speak to the patient every day. And if after 48 hours the diarrhea is gone, you can say, okay, that was axitinib, for example. If it hasn't gone, it's staying a bit worse, well, then you're going to intervene with immune therapy. Same rules potentially with transaminitis. And then, of course, you've got the specific immune related, a whole body rash associated with immune related tox. Of course, or myasthenia gravis, or of course, you're going to give steroids and go with the immune related adverse event and steroids. So, yes, clear VEGF TKI toxicity, stop the VEGF. Yes, a clear related immune therapy, either stop or put the immune therapy on hold, or certainly first intervention is to give steroids. And then there's this area in the middle where for some toxicity like transaminitis and diarrhea, there is an opportunity to maybe do a VEGF TKI cessation challenge. But if you are going to do that, be super careful. And then this leads us to team-based management and nurses, healthcare professionals, doctors, patients, and their family in the center of this web. I say to my team, we as oncologists need to be looking after the vast majority of this toxicity. Many of us don't have a cardiologist or a gastroenterologist in our clinic or an endocrinologist in our clinic. And therefore, we have to be familiar and comfortable with the majority of the predictable toxicity. Of course, the weird and the unpredictable, we need to be referring to gastroenterology for colonoscopy and cardiac for echo and support there. But in the end, early intervention with steroids for immune therapy and with treatment breaks for VEGF targeted therapy is really important. And patient, doctor, nursing, and health, that key oncology group, really important in getting patients across the line. And then there are goals for interprofessional communication and collaboration. And that kind of comes back to this commitment to evidence-based practice, which I feel is really important, clear communication channels, and getting this team working. And at our institution, our CNSs, our specialist nurses, and our pharmacists are in clinic with us, as well, of course, as the research team, and they're seeing patients in clinic with us. And that's a really helpful collaborative practice. And then one can look at some of these SMART goals which have been put together, and these look at some practical ways of looking after these patients. So key goal with that would be increasing the proportion of patients who are able to start treatment. And we still know, even in countries like the UK and the United States and France, that perhaps a third of patients in the frontline setting aren't getting a systemic therapy. We need to change that because it really just transforms the lives of patients, in my opinion. And of course, we're now looking at median survivals of 5 years. We need to expand the number of patients, in my opinion, who are getting a multidisciplinary approach, not necessarily multidisciplinary in terms of oncology, beyond cardiology, neurology, dermatology, gastroenterology, but multidisciplinary in terms of nursing support, pharmacy, and doctors, trained doctors, and of course, that support structure when they're not in the clinic, outside of the clinic, feels very important for me as well. Thanks for your time and your engagement. I hope you found at least part of this helpful. I think kidney cancer has changed hugely over the last 5 years. I think most of what I've said today will probably be true for a significant period moving forward, because while there are ongoing trials, most of them involve the drugs I've discussed today, given perhaps slightly earlier or in a slightly different way. So whether this will stand the test of time, I don't know.